Okay, for my talk today, I thought I would focus on craniosynostosis. Every year when we do mock oral boards, it seems like this is something the residents sometimes struggle with a bit. So this talk is really focused for the residents in terms of teaching about craniosynostosis, but we are going to talk about surgical techniques for it as well. So I have no disclosures. As an outline of the talk, we'll start off defining craniosynostosis, then talking about craniosynostosis versus plagiocephaly, different types of craniosynostosis, and then open versus endoscopic treatment, and then go through some sample cases to show what the results look like in these types of surgeries. So craniosynostosis is the premature closure of one or more sutures. The incidence is about 1 in 2,000 to 1 in 2,500. And sagittal synostosis is the most common of single suture craniosynostosis. Depending on what source you use, the numbers vary slightly, but around 50 to 60% of single suture non-syndromic craniosynostosis, or 40 to 60% is sagittal synostosis. Syndromic craniosynostosis accounts for about 8%. It's typically autosomal dominant rather than recessive, and bilateral coronal craniosynostosis is more likely to be syndromic than other craniosynostosis types. So if you see a patient with bilateral coronal, you really want to think about a genetics workup for that patient. In terms of the anatomy, we have the skull with the different sutures when you're born. Can you see my cursor when I move it?
Yes, you can see it.
Okay, so this is the coronal suture on the right side, and on the left side, the front suture here, which I know some residents said frontal suture, it's actually the metopic suture. And then we have the sagittal suture coming back and the two lambdoid sutures at the back. And this is how the skull grows over time. As the brain pushes out on the skull gets bigger and you have growth across the suture. The metopic suture closes around 3 months of age. The other sutures close significantly later, including into the second and third decade of life. So if you have trouble remembering what the different head shapes are, one of the things you can fall back on is Virchow's law. And this says that there is no growth across a fused suture and compensatory growth parallel to the fused suture. So if you have a suture here, for instance, the sagittal suture that fuses, then you cannot get growth in the lateral directions. And so as a result, you get additional growth in the anterior to posterior direction. So you then have an elongated head shape in the anterior posterior direction. There's multiple factors that can cause craniosynostosis. There are genetic factors. Multiple genes have been identified. But if you're just going to remember one, the fibroblast growth factor family of genes is the most important to remember. There are some environmental factors that may be associated with craniosynostosis: maternal smoking, white maternal race, advanced maternal age, gestation at high altitude, use of nitrosatable drugs, paternal occupation, including in agriculture and forestry, fertility treatments, endocrine abnormalities, and warfarin ingestion. But it's also important to remember that the growth at sutures is due to brain growth. And so if a brain doesn't grow, sutures will fuse. Now, that is not primary craniosynostosis. That doesn't need surgery. That's secondary craniosynostosis due to microcephaly or lack of brain growth. But this is important to think about because we frequently will get consults like this. The child has a very small head, they're an ex-preemie, all the sutures have fused, we think they have craniosynostosis. These are kids that just have a problem with the brain, not craniosynostosis. And then it's also important to remember that not all abnormal head shapes are craniosynostosis. So in the late 1980s, the American Academy of Pediatrics noted that sudden infant death syndrome was related to prone sleeping position. As a result, in 1992, they started the Back to Sleep campaign, and the incidence of SIDS decreased by more than 40%, which was great news. The incidence of positional plagiocephaly increased by 600%. So I would take this trade-off, death versus a cosmetic deformity of the skull, but it does lead to a lot of worried parents each year. About 19% of infants between 6 and 18 months of age are diagnosed with plagiocephaly, and actually the number that have some degree of plagiocephaly is much higher. So what is positional plagiocephaly? This is where you have flattening of the skull because the skull is thin and not very strong when a child is born, and so it's deformable with positioning. So if you have a baby and they're lying flat on their back, you may get flattening bilaterally, but in most cases, children will have a preference. If they're in the crib or the bassinet and the parents are on one side, they may tend to look to that side. And then they get flattening on one side of the head. This then pushes that side of the head forward with that ear moving more forward and frontal bossing on that same side. And you get this parallelogram head shape. So this is an example of what that might look like in a child. And you can see it can be a pretty significant cosmetic defect. And so you don't just want to say, well, this is markedly abnormal, it must be craniosynostosis. You really need to look at the shape. So the spiel that we give parents when they come to clinic, I start off, many of them have seen a helmet company first and gotten very scared. So they end up needing a lot of reassurance. Ideally, it's better if they just get referred to us or plastics first, but that is not always the pattern of referral. So I start off by reassuring them that this does not affect the neurocognitive development. There was a paper that all of us were worried about that got published that kids with plagiocephaly had worse neurocognitive development. This is likely because if you're delayed in your milestones, you lie on your back more and you develop more flattening. And so it's not that the plagiocephaly is causing the developmental issues, it's that developmental issues put you at risk for plagiocephaly. It's still important to reinforce that the child needs to sleep on their back. That's the safe sleep way, but we encourage tummy time during supervised awake time, and that's where you put the infant on their belly and allow them to look up and explore their world. We also often encourage looking at the sleeping arrangement. So for instance, if the bassinet or crib is positioned such that the parents or the lights are on the right, the baby always looks to the right, you move to the other side, and then that encourages them to look to the left. We also encourage them to limit seats that place them in the supine position. So rockers, strollers, things like that. If kids spend a lot of time in those, that will increase the plagiocephaly. In more significant cases, sometimes we'll recommend PTOT. This is particularly helpful if the child also has torticollis, and that's part of why they're turning their head. And then for very severe cases, we'll consider helmet therapy. None of us amongst the pediatric neurosurgery group here are big proponents of helmet therapy, but we will refer for severe cases. Plastic surgeons tend to be more pro-helmet, not surprisingly, since this is a cosmetic issue. But thankfully, our new plastic surgeon at Jackson UM, Dr. Lauren Yarhalar, is not a huge helmet proponent either. For helmets, we typically want to think about them about at 6 months of age for severe cases. If the child is younger than that, we have some time to use conservative measures and have that work. But if they get to 12 months of age, 85% of the cranial growth has been achieved by 12 months and they're less likely to work. So sort of that 6 to 7 month window is usually when we start a kid in a helmet if we think they have severe plagiocephaly. So what would you confuse plagiocephaly with? It's really lambdoid synostosis that would be the most likely to be confused with this. And thankfully, lambdoid synostosis is one of the most rare, form of craniosynostosis, while plagiocephaly is one of the most common things we see. So as we talked about before, you get this parallelogram head shape with plagiocephaly. In lambdoid synostosis, you get more of this trapezoid head shape. And the reason for that, both of them have ipsilateral occipitoparietal flattening and contralateral occipital bossing. But in plagiocephaly, the ipsilateral ear is anteriorly displaced, and then you get ipsilateral frontal bossing. In contrast, in lambdoid synostosis, this suture being fused pulls back the ear, so the ipsilateral ear is displaced posteriorly. You get contralateral frontal bossing because you have restriction on the ipsilateral side. So parallelogram shape, plagiocephaly, trapezoid shape is lambdoid craniosynostosis. So what are the other forms of craniosynostosis? You can have sagittal, lambdoid, unilateral coronal, bicoronal, metopic. So we'll go through those a bit. In terms of relative percents, I mentioned different sources have different percents. So this one had 40% for sagittal, but some sources will show up to 60%. Metopic about 30%, unicoronal 25%. Bicoronal and lambdoid are less common. And as we mentioned, bicoronal tends to be more likely to be syndromic. So sagittal craniosynostosis, these are some photos of one of my patients, and you can see here this very elongated head shape, significant frontal bossing, and they also get this occipital button. Since the growth is in the AP dimension, you end up very narrow from side to side and long in terms of the head. Metopic craniosynostosis produces a triangular shape head or trigoncephaly. You can grow in the width direction in the back, but you can't in the front. And so you get this ridge down the forehead and this triangular shape head. These are some photos of two of my patients as well. Unilateral coronal synostosis pulls the forehead and eye back on the affected side. So in this case, the right side is the affected side, and you can see how that's being pulled back. It'll also pull the orbit over and up. And so people will talk about the Harlequin sign with respect to the orbit. And then bilateral coronal synostosis causes a bracycephaly head shape, where you can see it's shortened in the AP dimension because it cannot grow front to back across these sutures. And you can also get what we call a pterocephalic head shape, which is a tower-like shape where the head grows up since it can't grow front to back. In terms of syndromic craniosynostosis, I'm not going to go through each of them in detail, but the three most important names to remember are Cruzon, Apert, and Pfeiffer. And those are all forms of syndromic craniosynostosis. And you can see you can have significant issues with the orbits and the eyes and risk of injury to the eyes because of how flat the face is. The FGFR2 mutation, as I mentioned, is really important in all of the fibroblast growth factor family. And when you think about the syndromes, you want to think about skull shape, what the midface looks like, and also look at the hands and feet. So Apert has moderate to severe brachycephaly with occasional severe turibrachycephaly, moderate midface hypoplasia, and then it has pansyndactyles of the hands and feet. So the thumbs may be free, but they have partial syndactyles and small fingers and toes. Cruzon's has brachycephaly, mild to moderate hypoplasia, and generally the hands and feet with Cruzon's are unaffected. Muncke is a less common one, so we'll skip over that. And then with the Pfeiffer types, we have three different types for Pfeiffer, ranging in severity. So for one, brachycephaly, moderate midface hypoplasia, broad thumbs and halluces, variable syndactyly. For Pfeiffer type 2, you have a cloverleaf skull deformity with pansynostoses, once again, variable syndactyly. And then Pfeiffer type 3 has pansynostosis with marked pterocephaly and moderate to severe midface hypoplasia. So how do you diagnose craniosynostosis? It's really a clinical exam. So in most single suture cases, you do not need any imaging whatsoever, and you're just exposing the kid to radiation if you're getting imaging. I really like seeing these children early. If you get them before 1 to 2 months of age, you can toggle the sutures. You put a thumb on either side of the suture and push up and down, and you can feel the movement in that suture to know for sure that it's open. But after that, the head shape is classic. And so the vast majority of children, to a trained eye, you can look at that head shape and you know what type of craniosynostosis they have and whether or not it's craniosynostosis. But occasionally we get cases that are sort of equivocal. They look somewhat like they might have craniosynostosis, but not totally severe. And then you can do low-dose CT scans with 3D reconstruction. It used to be that people would tend to do skull x-rays, but now the protocols for CT, especially if it's done for craniosynostosis, they tend to not use enough radiation to really give a good view of the brain and just focus on the skull, and that allows them to reduce the radiation dose and get nice pictures. So this is a CT of sagittal craniosynostosis, and this one unilateral coronal. So why do we operate on these kids? Well, the biggest reason is for appearance, psychosocial concerns as they get to be older and have very abnormal head shapes. But there's also a potential for increased ICP. This is more common in syndromic cases, and it's controversial how much of an issue this is in single suture cases. We know it does affect some children, but it's not. It's definitely not an absolute. But it is important to remember that 80% of infants with increased ICP will not have papilledema. So it's not sufficient to just say, oh, this kid doesn't have papilledema, they must not be under high pressure. And we don't want to wait till we see effects of high pressure and then have a child have issues. So in terms of impact on neurocognitive function, I'll just briefly go over two studies. Persing et al., who's John Persing, who actually is a duly trained plastic surgeon and neurosurgeon, who I had the privilege to work with as a medical student. He's actually one of the ones who introduced me to craniosynostosis, looked at non-syndromic sagittal craniosynostosis patients and found that patients treated later than 12 months had significantly worse IQs compared to those that were treated earlier. Speltz et al. Reviewed 17 studies from 1973 to 2003 and found that most patients had IQ scores in the normal range, but 35 to 40% had adverse neurodevelopmental outcomes. And so, when I counsel patients, I tell them that this is definitely a genetic issue, the potential for it affecting development. But interestingly, I was really taught as a medical student to downplay that we were operating for ICP and more focus on the cosmetic issue because we knew every child had that. But kind of ironic that that was by someone who showed that it affected potentially ICP. So in terms of surgery for craniosynostosis, when we think of this, we can think of it as three categories. So we have endoscopic surgeries. This is typically done at about 3 months of age. It requires helmet therapy afterwards for 23 hours a day, anywhere for 6 to 12 months postoperatively. We usually tell parents a year, and then if we're happy and we discontinue it early, they're pleased with that. But we want to make sure that they're ready and invested in having to go to helmet therapy appointments for that full time. Since it's needed. They spend 1 day in the hospital. Transfusion is rare. These children, when we operate on them at 3 months, are at their physiologic nadir for their hemoglobin hematocrit. You're born with a very high hemoglobin hematocrit, it then drops, and then it starts coming back up. And that 3-month range is the physiologic nadir. So we need to be very careful and meticulous as we do these cases. And we also have to work very fast. The faster and more efficient we work, the less blood loss there is. And that helps us to keep our transfusion rates low. Additionally, when I find these patients early, I'll often have their pediatrician start them on iron. That helps bump up the hemoglobin hematocrit and can help reduce transfusion rates further. For open correction, we typically do this at 6 to 9 months of age, unless the child is presenting to us later. And all of the remodeling is done at the time of surgery. So the advantage of this is that no helmet is required. They do tend to have a longer stay, about 3 to 5 days in the hospital, and transfusion is common because you do a big bicoronal incision and remodel the whole bone. And these are still small children who can't take a large amount of blood loss. The third method, which none of us here do, but some centers are proponents of, is the use of springs. So this is done at an in-between age. A strip craniectomy is done, and then springs are implanted to widen the skull across that area. So the advantage of this approach is you don't need a helmet, but the child does have to come back for repeat surgery several months later to remove the springs. So we'll just go through a couple sample cases. Okay. So just to give you an example of sort of open correction versus endoscopic. This is an infant who had sagittal craniosynostosis, and this is his appearance preoperatively. You can see his elongated head shape, frontal bossing, and from side to side. For him, it's pronounced when you look at him from the front. He's not quite as severe when you look from the top. And then this is him about a month after an open correction. You can see his incision goes ear to ear. His width of his head is wider, and the front and face look more normal. This is another child who had an open correction. This child, instead of being about a month out, is about 9 months out from his surgery. And you can see, even though everything is done in one case, we do see some continued improvement as they age. Unfortunately, don't have pre-op images for him. So both of these patients had what we call a digitiform expansile cranioplasty. That is a technique that was pioneered by Dr. Anthony Wolf, who's one of the senior plastic surgeons at Nicholas Children's. One of those cases I did at Nicholas and one I did at Jackson. And you can see here on the skull, The whole skull is exposed when we do open surgeries, and we make out drawing on the skull of where we want to make the cuts, with a piece here and then another piece here. And then we make interdigitating cuts going across the sinus. As you can imagine, we need to free up over the sagittal sinus so that we don't injure as we make these cuts back and forth. And we typically will hold up on the bone so that we can actually directly visualize as we're using the foot plate going back and forth across the sinus. This is the coronal suture here and the tuber holes that are made just posterior to the sagittal sinus. One thing of note with this technique is that we don't actually do anything with the frontal portion of the head, but it still does improve postoperatively. And then these struts are separated out and secured in place with sutures in order to widen the skull. You can see that here as well with these gaps. So for this band, the band would go across and the gap is on the other side, whereas on these two, it's on this side, and where that gap is alternates on the two sides. There are many different techniques of how to do open cranial vault remodeling, though. This just to give you an idea, lots of different cuts for coronal or for metopic. Patients have a frontal orbital advancement where you actually take off the front of the skull and the top of the orbits and you move that forward and secure it in place. For some open remodeling, people will remodel the occipital button if a patient is very severe in the back, or the front if they're very concerned about the front. So there's lots of different variations on open cranial vault remodeling. The other approach to this is endoscopic. These are two images of patients positioned in the operating room for their endoscopic craniosynostosis surgery. We put them on a horseshoe. Some people will use the modified Sphinx position where the patients are like this with their head up. And a Doro head holder, which is a gel head holder that's specifically designed for pediatrics. That works great, but we do not have that head holder at either Jackson or Nicholas. We tend to use the horseshoe and just position them prone. You can see here the anterior fontanelle is marked out. The lambdoid sutures are marked out. This is where lambdoid comes up on either side and meets on this child, and the anterior fontanelle on this child. And then we plan 2 incisions over the sagittal suture. You may notice that the posterior incision is closer to the lambdoid than the anterior incision is to the anterior fontanelle. That's because typically the dura is more stuck posteriorly, and it's easier to have this area be smaller and make longer cuts towards the fontanelle. And then you need this distance to be such that you can fit your scissors in to cut. So we end up removing a strip of bone like this that goes from the lambdoid suture to the anterior fontanelle. So to give you an idea of that, this is making the incision on the anterior cut. We then drill a burr hole on either side of the sinus and free up over the sinus. We'll use progressively larger carousins in order to take off some of this bone, and it is important to work up to larger carousins fast because you can imagine that you need less bites if you have a larger carocin, and you can go faster with less bleeding if you're taking larger bites. Once we take off an area of bone that we can get our scissors in, then we're going to make cuts anteriorly to the fontanelle, or in this case, this is us going posteriorly from the posterior incision back to the lambdoid suture. This is the picture of going anteriorly towards the fontanelle. And this is just to show you with the 2 incisions, we can have a lighted retractor to shine in. We also use the endoscope coming under the bone towards the fontanelle or from one cut to the other to show that we are freed up and have gotten across the path we need. And then this is an example of the amount of bone you take out. Typically, we want to be about 2 to 3 centimeters. I tend to go on the wider side in order to have this procedure work as well as possible. These are the scissors we use, and we're using this to cut through bone. So that's why 3 months of age is sort of the ideal time. Once kids get into 4 or 5 months of age, it's much harder to have these scissors work to cut through the bone, especially since you're using them underneath the skin. And then this is an example of how you pull a strip out through your incision. So your incision needs to be at least as wide as your cuts. And then you end up with these 2 incisions. And to show you an example of the case, this is one of the first patient that I showed you with sagittal craniosynostosis. with sagittal craniosynostosis. And this child actually had a really remarkable postoperative result. Normally, you get a little bit of widening with the surgery, and then the helmet does the rest of the work. But these are his photos from post-op day 1, and you can see already his skull is much wider, and the frontal bossing is significantly improved. So this says to me that he was under high pressure, because the only thing that we're not pushing the skull out. So what's working to push the skull out is the brain. And I think this is a further argument for thinking about doing these kids endoscopic when they're picked up early, so that if they are under pressure, you release that pressure early. And actually, one of those open cases, the one that was more recent, the mom actually did, or grandma who has custody mentioned that she felt the child's development substantially improved postoperatively, which could suggest that he had some issues with that as well. And then this is about 1 to 2 months out from the surgery. So he's been in a helmet. We've struggled a bit with the helmet company. They initially were putting some pressure on the side of his head, which is exactly what you don't want. Now they're going in the right direction. And so you can see significantly wider head. You can't even really see the incisions. They've healed up nicely, and his frontal contour is substantially improved. For Metopic, this is a child that I did a Metopic case on a little while back. You can see very triangular head shape with a ridge in the Metopic region. We position these children on their back, and we make a small incision just behind the hairline so that it will be hidden by the hairline, and then take a strip of bone from that incision down to sort of above the nose here. We try to get as low as possible, so it ends up being wider up here. In this region, it has to be a little bit narrower so you don't get into the orbits. And this is the most challenging part of the cuts, because the bone here is very thick and very bloody. So we use the sonopet claw angled up in order to come up through that bone. So this is these are his pictures immediately post-op in the OR. And you can see you're not totally fixing the head shape in the OR. It's maybe a little bit wider in the front, but the bulk of the work here ends up being done after releasing the suture by the helmet. This child, despite, I always go over with the families how important helmet therapy is and the need for helmet therapy, and won't offer the procedure to families that I don't think will follow through with helmet therapy. But this child did struggle a bit to get in the helmet early on. In spite of that, I think he got a pretty good cosmetic result. So comparing the 3 time points, here's pre-op, immediately post-op, and then this was about a year out. We have those photos. This is another child with Metopic craniosynostosis. See the significant ridge that was noted at birth, and his triangular head shape. This is him about 1 to 2 months out from the surgery. And this is a photo that his mom sent me last weekend of how he looks today. He's about 2.5 years old now. So I would say when I started out as an attending, I was somewhat equivocal on endoscopic versus open, and I'm moving more in a direction of thinking that endoscopic is really the way to go for these kids that we're picking up early. So just briefly to go over the cuts. So this is for sagittal synostosis, 2 midline incisions, Metopic, 1 incision towards the front. For coronal, we do 1 incision. Often I actually put it a little lower than this, but it's between the fontanelle and squamosal, and you need to come down. Coronal, unilateral coronal is the hardest of the endoscopic ones to do, because if you don't come all the way down, you're not fully releasing the suture, and you won't get a good result. They also tend to be more challenging to get great results with open. It just really causes severe deformity when you have unilateral coronal. So in summary, if you're going to remember anything about surgeries, you want to focus on endoscopic versus open. So endoscopic, about 3 months of age, helmet therapy, long-term after the surgery, 1 day in the hospital, rare transfusion. Open, 6 to 9 months of age, remodeling, all done at the time of surgery with no helmet required, and a 3 to 5 day hospital stay with transfusion being common. And then obviously the other take-home point is that you want to remember, is this craniosynostosis or is this plagiocephaly, since craniosynostosis is operative and plagiocephaly is not and is actually more common. So with that, I'll take any questions.
Yes. Okay. So good morning, everyone. Sorry about the delay. Today we've got an outstanding speaker, Dr. Patrick Ganser. Patrick was recruited to the University of Miami with the Department of Biomedical Engineering. As you know, the Miami Project and the Department of Neurological Surgery are very, very interested in bringing new technologies to the field of CNS injury and repair. And Patrick is just an outstanding researcher at Ohio State that works with a lot of companies. And I think that's really important to the neurosurgeons on the call that are reaching out to places like Patel, Memorial Institute, and other firms that are developing the newest technologies that can be targeted to our neurological problems. So when you think about Patrick, he works both in the preclinical arena as well as the clinical arena. And we thought that he would be a great recruit, dual recruit with the Miami Project to bring to the University of Miami. His laboratory will be on the first floor, and he'll be working with our biomedical engineers and many of our scientists in the Miami Project, and hopefully many of the neurosurgeons in the Department of Neurosurgery that are interested in bringing different types of innovative approaches to the laboratory. So if you look at his CV, he's got a very rich CV that involves scientific expertise in the area of electrophysiology, cardiovascular physiology, neuroanatomical molecular assessment, surgical techniques, behavioral assessment, machine learning, and big data. His grants right now are with DARPA, as well as Wings for Life and Spinal Cord Injury and other various foundations. He has several projects ongoing targeting, for example, a closed loop bioelectric medicine that's stimulating the trigeminal or the vagus nerve branches to target cardiovascular system, which is obviously extremely important in our population of spinal cord injury subjects. He also does intracortical brain-computer interface work, which the Miami Project, of course, is extremely interested in pushing forward, as well as the next generation neurosurgical neurotechnology programs with DARPA. And he's working with colleagues at the University of Miami and other universities, pushing forward the magnet electric nanoparticles, which are a really nice and new way in which we may be able to stimulate areas of the brain and the brainstem non-invasively. And I think that's going to be extremely interesting for our next generation of neuroscientists and neurosurgeons. So when you look at Dr. Ganser's profile, and I think he's joined us, I see him on the Zoom right now. Good morning, Patrick. How are you?
Hello, everyone. How you doing?
I just started the introduction, so we ended a little bit early. When you look at his profile, Patrick talks about being an engineer and specializing in closed loop electronic medicine, in vivo physiology, applied artificial intelligence, brain-computer interface, and translation of technology to the clinic for human needs. So I think everyone's going to be really interested in what Patrick is to say today. And here's his title: Replacing Pills with Electricity. I love that title, Patrick. Thank you very much. And this is my introduction to our neurosurgical colleagues, residents, and other neuroscientists and Miami Project researchers throughout the university. So again, Patrick, thank you very much for joining us at the University of Miami, and we all look forward to your presentation.
Great. Thanks, Dalton, and thank you for the kind introduction. Sorry, I guess I'm early, but kind of late since we finished early.
Exactly. Yeah.
That's maybe a first for me. So looking forward to the interaction and the feedback on the content today. Obviously very excited to have your time. As Dalton might have mentioned, I might have missed it, I'm an assistant professor here at the University of Miami, jointly appointed at the Department of Biomedical Engineering and the Miami Project, and be talking today, maybe the title's a little bit provocative on purpose, be talking today about really neuromodulation, preclinically and clinically, but something, I guess, retermed called bioelectronic medicine. It's a new thrust in the field. And again, excited to get your expert clinical feedback on some of the content today. Can you see my presentation okay, and the volume is good as well?
Everything's good, Patrick. Thank you.
Great. So just to give a little bit of structure for what we'll go over, and Dalton, are we going to hold questions to the end or just hop in?
Usually it's to the end, but if someone wants to ask a question, they can do it in the chat, or they can just break in. That's fine.
Okay. If you just let me know if anyone has a question in the interim, I won't be monitoring the chat too closely. But yeah. So we'll first start off with just a broad definition and really explanation of what is a bioelectronic medicine. And really up front, it's neural, or mainly we'll be talking about nerve stimulation to treat disease and dysfunction. After some of the background content, we'll get into some more specifics. We'll be talking about throughout VNS, or vagus nerve stimulation, and its first really use and application as a booster of rehab. So we'll get into how that works, how it's implemented preclinically as well as in the clinic. First starting with historical data in treating patients that unfortunately have an ischemic stroke and therefore hand paresis and hand dysfunction. Looking at the preclinical data and then the clinical translation all the way through pivotal recently, and really excitingly last week, FDA approval. So you'll be hearing some of the history of what I think is one of the coolest and really most robust, seemingly in terms of clinical applications, bioelectronic medicines. During my postdoc, focused on using this same approach, which we'll be talking about, again, boosting rehab with nerve stim, preclinically for spinal cord injury. That's now gone into phase 1 clinical trial, which we'll overview. And the last content that we'll be bringing up is really based on, if we have this VNS implant, what else can it do, right? There's a lot of comorbidities that occur either before you have a stroke or after spinal cord injury. So we'll be talking about closed loop control of VNS to modulate cardiovascular pathophysiology and specifically myocardial ischemia. Does it work? And really in preclinical models. Hopefully I have some time for questions. So really briefly, some of you may already know what a bioelectronic medicine is. Won't go into great detail. It has a lot of contrast with molecular medicines, of course, that depending on the route of administration, if it's a pill, if it's an IV injection, can affect a number of tissues if it's going through the blood supply, which then tells us a little bit about its selectivity. Some pills and IV XYZs, whatever your molecular agent is of choice, can be slow acting. It'd be really nice to have a pill that acts right away, and really something that we can maybe turn on and off easily. So these are some attributes of molecular medicines that bioelectronic medicines impart, seek to address, again, using nerve stimulation. And so specifically using either brain, or we'll be talking about peripheral nerve stim, we can potentially achieve more selective effects by selecting a specific nerve that then goes to maybe even a subset of an organ to affect function. Nerve stimulation can also be very rapid, so it's almost instantaneously affecting physiology in some cases. And we'll be talking about really reactive nerve stim throughout the rest of the slides, where we can turn it on and off and maybe react to disease events that are episodic and spontaneous, what we call kind of closed loop stimulation. So these are some attributes to keep in mind and some contrasts with molecular bioelectronic medicines. Diving into more detail, we mentioned at the onset, we'll be talking about vagus nerve stimulation throughout. VNS is becoming quite prominent in the field of bioelectronic medicine. It's FDA approved for treating epilepsy and depression and many other indications. Left cervical VNS is also what we'll be talking about specifically. This is, hopefully you've had breakfast. Sorry for the image. This is an example of what the implant looks like. It's an outpatient procedure. Some of you may have done these implants. I don't know. Some of you may already know this, like the back of your hand. Sorry to repeat any content, but this is what the interface looks like. And of course, the vagus is connected to many, many things, many organs, many downstream cerebral targets. We'll be talking about using it to electronically control and enhance brain change or plasticity. So in this cartoon schematic to the right, we see that the vagus is feed-forward connected to many things, including the locus coeruleus and nucleus basalis, which when they're activated, lead to the release of acetylcholine and norepinephrine, which are two of many plasticity or change-promoting neurochemicals. They can help the brain enhance or weaken synaptic connections between circuits, therefore changing neural connectivity. You can also even enable structural plasticity with the release of these chemicals by growing new axons. This brain change may be important to control if you have a brain injury and you want to rewire damaged circuits, or you want to regrow things that are damaged in order to get connections back to maybe muscles. And we'll be talking about doing this to enhance rehab in the next handful of slides. So we call this instantiation of closed loop VNS. Again, it's not turned on and off pre-programmed. We'll be talking about using it in a closed loop fashion. We call it targeted plasticity therapy. So you've already heard plasticity. Targeted is self-evident. We can maybe target events in time by briefly stimulating the vagus and targeting neural circuit activation so that we can enhance its plasticity and grow new connections associated with it. There's a lot of funding agencies that are getting into funding bioelectronic medicine efforts. Some are at DARPA, NIH, one of which is of note, was two programs funded, or rather created and funded some of this work at DARPA, created by Dr. Doug Weber, who is a former DARPA PM and a close friend and colleague. The programs were called Electrics, which stands for Electrical Prescriptions, and TNT, which stands for Targeted Neuroplasticity Therapy. So we've seen this schematic where we can zap the vagus and electronically control plasticity promoting molecule release. And we'll be talking about using it in the motor system. So this is a cartoon schematic of how it works. I won't get into any of the great details. This is a long list of preclinical data. But if an animal or a human is engaged in a motor task, there's of course associated neural activity. Let's just say in the brain, in the cartoon at the top. The green neurons and yellow neurons become activated. If you pair this neural activity, and this is really important. This is basically if you want to go to sleep, but you want to know how targeted plasticity therapy works. This is the gist. If you pair neural activity associated with a movement with vagus nerve stimulation repeatedly, you can grow and enhance that circuit. So you can change the brain using nerve stim that's targeted in time. So really targeting specific events shown here at the bottom. And so this can potentially be used to enhance brain change after injury and even enhance function after brain injury. So this slide is really about some of the historical data using this rehab booster, again, pairing VNS with good movement after different kinds of brain injury. You'll see throughout the presentation red or blue. Red is pairing movements repeatedly with vagus nerve stimulation. We'll be talking about the rodent data here, as well as the clinical data in the next handful of slides. And animals or humans in the blue group is standard rehab therapy, which we know has some effectiveness, but it's not perfect. And maybe we can enhance it and boost its effects for recovering function. So after traumatic brain injury, on the y-axis here is a correlate of forelimb strength. Animals become weak. We know that humans can have TBI insults to impair forelimb control, and repeatedly pairing VNS with good movements during rehab over many weeks, again, thousands of movements, boost the effects of rehab, even when you turn VNS off. So during the last week, these are long-lasting improvements. Again, just breezing through some of the historical data, happy to answer questions later. This has been tested also after intracerebral hemorrhage. So again, you get a drop in function, forelimbs are weak, and you stratify animals into either standard rehab or rehab boosting VNS plus rehab. So again, a nice preclinical indication that VNS can enhance forelimb recovery, not back to normal, but close. And lastly, and really this is what's been translated to human applications excitingly in preclinical models of ischemic stroke, so using endothelin-1 injections to mediate intense vasoconstriction and necrosis. Again, same story and similar effect size too, regardless of brain injury. So excitingly, this is, of course, translational research, which getting things into the clinic, as you know, can be very expensive and complex. I'll go over in this slide the clinical translation of VNS plus rehab, again, a rehab booster to see if it works in humans. And this has made it through pivotal trial recently, which I'll overview briefly on the slide. This is a snapshot of the results from the phase 1 effort. Up top here is a schematic of how the therapy works. So individuals who unfortunately have arm and hand dysfunction due to an ischemic insult have an implant on the left cervical vagus, which again gives you electronic control of plasticity enhancing neuromolecule release. When good movements happen, a physician will trigger stimulation in order to pair that neural activity that's weak and needs to be boosted with VNS and acetylcholine and norepinephrine release. So this happens over about 6 weeks. The effect size is reasonable compared to some of the preclinical studies. This was, again, a phase 1 trial, just mainly focused on safety. But you see you get a reasonable Fugel-Meyer shift of about 7 or 8 points. The phase 2 effort was double-blind, placebo-controlled with a crossover. So similar effect sizes, again, not appropriately statistically powered, but still a boost of forelimb function as measured by Fugel-Meyer, and individuals in the rehab group that crossed over had a similar enhancement. So this is, again, another exciting glimpse at effectiveness of this therapy in humans with stroke. And lastly, this is an overview of the pivotal trial, which was just published in Lancet this year. Again, showing similar effect sizes, about a 5 or 6 point Fugel-Meyer shift, which then mediated approval last week by the FDA. So this is very exciting for the field of bioelectronic medicines and exciting to help people and really to be a part of this preclinical to translational pipeline. So this is an overview of the stroke work showing its promise in Texas with the very talented team there, which really pioneered this targeted plasticity therapy. We also focused on assessing if this can work after not brain injury, but spinal injury. So again, preclinical models, starting off with that in rodents, either using unilateral or bilateral contusion of the cervical spinal cord in order to insult many things, including forelimb function. This is some of the gross histologies, so coronal sections of the cervical spinal cord showing the lesion. I'll give a little bit more detail into how the therapy works. You've seen some of the data of forelimb function dropping and being boosted. This is what you could call it the rat gym or rat rehab. It somewhat models human rehab, where the animals will learn to, in this case, interact with a pull handle and really show how strong they are. Animals can actually pull almost their total weight. So this is operantly conditioned. You get lots of trials and you get lots of really rich data on forelimb function. So you can not make pairing qualitative, but you can pair VNS quantitatively, knowing how much force, how much speed was in the movement, and what was a good movement or bad movement. We'll talk about sensorized rehab devices for human use in just a few slides as well. So the VNS interface, again, is on the left cervical vagus nerve. It's a bipolar cuff. We stimulate at 0.8 milliamps, 30 hertz. I'm glad to go into more detail if anyone has questions on the experimental granularity. If a good movement occurs, you pair VNS. Again, just more details on how the actual therapy works. You pair VNS just for half a second. So that's enough to get chemical release throughout the brain. The other group, again, in blue, is your standard rehab that just does task practice with no stimulation. So this work was published in eLife first, and there's been many follow-on works to look at if this can actually boost, preclinically, recovery after spinal cord injury. It's been covered by many colleagues in the field, including Reggie Egerton and others. And the team that really attacked this was multimodal and loaded with talent, some of which are shown below here. Michael Darrow and Eric Myers were biomedical engineers on the project, and Michael Kilgard and Rob Renneker were really the inventors and part of targeted plasticity therapy and the co-PIs of the group. So a fantastic team down in Texas for this effort. So in this set of work, again, this is really just the data for the SCI assessments, is just this 2 slides. We asked many questions. At the onset, we mentioned bioelectronic medicines could potentially be turned on and off. However, what would the timing requirements be during rehab? Can't I just stimulate the nerve consistently during rehab? Do I have to pair it really precisely with the movement? And long story short is this is a nice attribute of a bioelectronic medicine. If you can close loop stim and there's a timing requirement, it could be temporally precise medicine. And timing does actually matter after injury and pairing a stim to get maximal recovery. So at the top right here is really the first evidence of 2 things. Number 1, that VNS can, paired with rehab, can boost recovery. Again, a preclinical demonstration after spinal cord injury. And number 2, that you have to pair it temporally a certain way. There's a window of opportunity. So again, red versus blue, which I mentioned at the onset, you'll see that throughout. You get an enhancement of forelimb recovery here. Again, even if you turn stimulation off, so the recovery is lasting compared to rehab. And in the black group, we gave the same amount of VNS as we did to the VNS plus rehab group, except we paired that with bad movements, which showed, even though you have the same amount of stimulation, it showed no enhancement of recovery, really identical recovery to rehab. This then indicated that there might be a timing window really of opportunity of when you need to stimulate. So here you see 3 groups in the study showing on the y-axis how much more of a benefit in forelimb recovery do you get versus rehab. If you precisely pair movements, really immediately, good movements with VNS, you get about a 60 or 70% benefit. If you delay it 2 seconds, you start to see a drop. And in the black group, even though we paired it with bad movements, they were separated by about 25 seconds from good movements. And so it'd be nice to fill this function out completely, but you get the idea that there might be a window of opportunity where neural activity is highest and you need to pair it with those neurochemicals to get maximal benefit. The last data slide here is actually the first evidence of how this might work, again, in rodents, and that it actually does enhance brain change and neuroplasticity. So in panel A is a repetition of the effect that VNS enhances recovery after spinal cord injury when paired with rehab. So you get your enhancement here, a similar effect size, about double or triple the benefit of rehab. And in these animals, if you look at their motor cortex and you map out what that tissue is attached to in terms of what muscles it moves, the groups that had the really the maximal benefit, the rehab boosting, also had about 5 times more brain area motor cortex connected to the really important and disconnected grasping muscles. So there might be a rewiring here. Again, VNS can enhance structural plasticity to these muscles that are important for forelimb function and strength. And lastly, in panel C here, I'll go over this briefly. This is a neuroanatomical assessment of some of the structural changes after injury and therapy using an agent that can be injected into the muscles. It makes neurons glow green that it infects, and it moves across synapses retrogradedly. So it's a transsynaptic tracer that allows you to look at neuroanatomical connectivity with these really important grasping muscles. This is an example of some of the histology in cortex. And long story short, this allows us to look at different modules along the sensory motor axis that's connected to these important grasping muscles. And in the groups that had the highest amount of benefit, we see maximally cortical neuroanatomical plasticity. Again, that in some capacity corroborates the cortical mapping data. So this is very exciting and has now led to the translation of the therapy to humans. So I'll talk a little bit about what the team has done in Texas. Dalton has a question.
Yeah, Patrick, and just a little bit clarification. What does bad movement actually mean in terms of the rodent movements?
Good question. So the rodents will be able to pull after injury a gram range, right? So that's how we quantify, if you remember the force profiles here. So once you have the force profile range statistically, we consider in this slide here, it's listed the top 20% is the best movement. So that's really the strongest. And then in that distribution, the bottom 20% was the worst movement. So it's quantified in terms of what they're able to achieve a priori. Clinically, that can get messy and complex unless you're quantifying it, and there's really guidance and guidelines of how to do that. But that was how we instantiated it using the force profile data.
And is the result specifically unilaterally observed, or is there a bilateral effect with this approach?
That's a really good question. So the animals learn to do this task with their right limb. And we have never assessed generalization in the rodent data to other recovery outside of the trained limb. We do see that on training and enhancement on certain movements, we see the forelimb strength task here, which is a pull task. The rodents can actually turn doorknobs to look at supination, pronation. So there is generalization from strength to dexterity with this therapy. We've seen that clinically. However, we've never looked at, does training and enhancement in one limb go to other limbs? That's a really exciting question. I don't think that's been appraised clinically as well either.
Thank you.
Yep. So the preclinical data is exciting, and the clinical translation of this, of course, piggybacks in some capacity on some of the stroke translation. And the way that therapy is instantiated. Nothing's perfect, so we always want to improve on how we're disseminating these therapies. It might be possible to improve access to care, so individuals don't have to come into a rehab hospital. Maybe they can do this rehab at home. Can we automate the VNS delivery if they're doing this therapy at home? How do we track what the forelimb's doing? And overall, the team made a number of improvements, again, trying to get this therapy sharpened and better, and access to, in this case, spinal cord injury. The improvements were funded by a number of institutions, including DARPA, Wings for Life, and the Caruth Foundation. I mentioned sensorizing objects in order to have the individuals use this at home. This is an example of one of the systems called Replay, where you have hockey pucks and other things that allow you to look at the degree of wrist rotation, wrist extension, pinch strength, things like that, where you can get data. I'll show how these work on the next slide. So this is one advancement in how the rehab is delivered. Another advancement in the therapy is miniaturizing the IPG and really making it wirelessly powerable, as well as you can communicate with it wirelessly. So there's no battery implanted. And so this has now been translated again to a phase 1 trial, which is very exciting. Again, honored to be a part of this work and very excited to see how this plays out with regard to effect sizes and helping individuals with spinal cord injury recover hand function. The next slide here is really just how this replay system works. In order to make rehab potentially exciting, the pucks and the other objects are connected to video games. so that you can maybe engage in something. And also here on the top right of the panel, as Dalton kind of was insinuating, look at good and bad movements and really quantify when do I pair VNS. So there's a really rich repertoire of video games now, and the adherence to this is actually good as well. So this is the paradigm that they're using in the phase 1 trial. It's be very exciting. A lot of open questions and new things too. So in closing here, the last, I guess, handful of slides, we'll be pivoting to, as I mentioned in the structure of the talk slide, using VNS, so the same implant, for potentially other comorbidities. So yes, a stroke and spinal cord injury can impact sensory motor circuits, leading to disruption in hand function. But of course, there's a precedent or even subsequent cardiovascular dysfunction that occurs after or before these injuries. And so the vagus is, again, as I mentioned, and as you know, connected to many different things, cerebral targets as well as visceral targets. You can pick your comorbidity or dysfunction that occurs either during spinal cord injury and stroke, and maybe come up with a good hypothesis of how VNS can help. We'll be talking about using vagus to control cardiovascular state throughout the next handful of slides, which can have a myriad of implications, including preventing what we call myocardial ischemia, and furthermore, even autonomic dysreflexia down the road. So this is very new, unpublished data using the same implant, really, to control potentially and boost rehab, as well as maybe control in a closed loop way cardiovascular problems. So what can this implant do? Can we maximize it and use it for a number of things throughout the day? So just a brief overview. Some of you may be experts in cardiovascular disease and ischemia. Sorry if I'm simplifying things. Just a little bit of background here. So as many of you may know, myocardial ischemia is a huge problem associated with cardiovascular disease. It occurs when there's either a decrease in oxygen supply and or an increase in oxygen demand. If it's prolonged, you can of course have myocardial injury and even transmural necrosis and an infarct, which can of course be unfortunately fatal. One thing that's maybe underappreciated during myocardial ischemia is, yes, it could be associated with angina and chest pain or no symptoms at all. But the vast majority of ischemia events are asymptomatic. So your heart is being potentially injured and you don't know. And even up to roughly 50% of heart attacks can be purely asymptomatic. So this highlights a huge problem in our biological neural networks. Maybe we haven't evolved or just aren't equipped with the sensory capability to really detect episodic, potentially fatal cardiovascular events. This might be an opportunity for machine learning to come in and supplement our biological neural networks. And really that's what we'll be talking about more specifically in the next handful of slides. This is schematized here in the cartoon. Again, specifically talking about the cardiovascular system and the heart. It gives off and B, a lot of data, depending on if you want to use a wearable lead-to ECG monitor, even clinically interarterial blood pressure. You can pick your wearable data or non-wearable data and get rich information about cardiovascular states that you can then pass to machine learning architectures in panel C to really decode this complex data set. Is the heart in a good state? Is it becoming ischemic? And so forth. And if we can detect ischemia and other events accurately, who cares? Can we actually do something about it? And so in panel D is an example of triggering VNS to potentially decrease things that are elevated during at least demand ischemia, which would be chronotropy, inotropy. VNS and its cardiovascular control is well studied and has been shown to mediate coronary vasodilation. And the reason VNS is overall attractive is that through a number of mechanisms could potentially increase O2 supply and or decrease demand and therefore prevent injury potentially and reverse myocardial ischemia. So that's a schematic of exactly how the therapy is going to be instantiated in the next slides. And just one more method slide on how we Induced myocardial ischemia, again, preclinically here, you'll be seeing data in rodents. We use two maybe boring and classic catecholamines, and maybe even clinically relevant, and infuse them at high doses in order to have somewhat of a catecholamine rush and disrupt energetic imbalance in the myocardium. The first of which is dobutamine, which is used in many stress echoes where doses are scaled up in order to potentially provoke abnormal wall motion and or other correlates of ischemia in humans. Well-studied catecholamine. And the second that we'll be using to induce myocardial ischemic states is norepinephrine. Again, not a fancy drug, more of a boring molecule perhaps on purpose. It's implicated in a number of stress states, and specifically at high doses, which we do use in the study. Norepinephrine can readily disrupt and lead to electrocardiographic evidence of ischemia via ST segment deviation, mediating even coronary vasospasm. And if these infusions are prolonged, you can readily get a transmural necrosis and infarct due to the catecholaminergic overdrive. So these are the two drugs that we'll be infusing, again, into rodents to evoke acute episodic myocardial ischemia. For the, again, in red as a summary, the following reasons: to disrupt energetic imbalance precipitously and potentially provoke ischemia and or injury to the heart. So the model that we use in the rodents is motivated by a lot of clinical factors that are seen in myocardial ischemia, where you have an increase in heart rate, an increase in afterload and mean arterial pressure, which will then increase myocardial oxygen demand and rate pressure product. Usually these events have to be at least 30 seconds in order to be considered myocardial ischemia. And so this motivates some of the data here at the bottom of the slide. Specifically, we record a lead-2 ECG in rodents to look at electrocardiographic information and just heart rhythm, and also an interarterial blood pressure waveform from the right carotid. So it's the cartoon of some of the sensor data. You'll see here throughout the next handful of slides, again, I mentioned the previous slide, the catecholamines. Anything in green is an infusion of a high dose of dobutamine alone, which you see here is the green D. Anything in blue is norepinephrine alone. And anything in cyan is a combination of the two catecholamines to get a maximum catecholaminergic kind of drive and rush to the heart. So these three different cardiovascular stress states via infusion differentially impact rate pressure product, which is an index of myocardial oxygen consumption. So the heart is using more oxygen, it's beating faster against a more resistive vasculature. And panel C is a classic electrocardiographic signature of subendocardial ischemia, which may be maximally affected by the combination of dobutamine and norepinephrine. We see ST segment depression in many mammals, including humans, as a potential indication of ischemia. And in panel D, again, this is a snapshot of the many bad things that happen during these infusions, is something called QTC prolongation, which is indicative that the ventricle's action potential is increasing in duration, which can lead to bad things, including arrhythmias. So this is a quick snapshot in B, C, and D of how these three different stress states differentially impact these biomarkers. Just to show a little bit of raw data, in panel E is a representative cycle averaged ECG in gray during rest, or in cyan during the combination injection, showing classic electrocardiographic ST segment depression, as well as QTC prolongation, mainly contributed to by the extension of the TP end component of the repolarization wave. Lastly, again, a snapshot of just what the model does. In panel F and G is a summary of the arrhythmias, which can be a consequence of ischemia and therefore leading to electrical instability in the heart. We commonly see three different kinds of arrhythmias during these stress state inductions, including ventricular tachycardia. The ECGs are at the top, the simultaneous blood pressures are at the bottom. In the middle is an example of premature atrial contraction. And we also see PVCs, or premature ventricular contractions during these stress states. The maximal effect on arrhythmia incidence, not surprisingly, happens during the maximal impact of catecholamines via the combination dobutamine norepinephrine. So overall, this is really some of the electrocardiographic and hemodynamic data that gives us an idea of all of the things that are going on that are challenging to decode. If we're getting these data from sensors, can we decipher this and use AI? And furthermore, can we reverse these things using nerve stimulation, right? This is the make it bad, can you do something good? Next. So I'll give you an overview of the decoding approach. So we use AI. AI is kind of a loaded term. It's really advanced machine learning here. This is an example of the deep learning architecture. So it's a network that learns to decode these different states. Even though they're complex statistically, they're very noisy and they overlap. The first step is we take a snapshot of some of the cardiovascular features, including ECG wavepoints, as well as blood pressure wavepoints, and really just to get an idea of what's happening at a given time point. We feed this into the network over time in the red layer. This information then goes to the purple layer, which looks at patterns between the inputs in the red layer. The blue layer of the network, the third layer, gives the network memory. So it allows it to look back in time if needed in order to better predict the future. Is this state XYZ? Do I have to look back 30 seconds or just 1 second? And lastly, the algorithm is trained to accurately decipher, we'll just see some of the performance data, the 4 different states. So either the rodents are at rest, they're either under dobutamine stress, norepinephrine stress, or the combination of catecholamines. This is an example of what the algorithm does when it guesses over time. The infusion here of the combination injection happens at the vertical black dash line. And the algorithm goes from a 0, which is, this is definitely not the cayenne combinatorial state, to this is definitely a state. So this is the algorithm guesses from 0 to 1 across those 4 cases. And that's really how it guesses. And we can maybe use this to, of course, decipher these complex stress states, as well as decode, excuse me, decode and trigger nerve stimulation as well. So if you can detect it, can you do something about it? So I'll be talking just a slide here about the closed loop control. So really quickly, just in the sake of time here to get to some questions, the algorithm performs very well. This is really noisy data. Ischemia is very noisy in humans, as you might know, even within a subject. It can happen at different hours of the day. Overall, this is what the algorithm guesses, averaged across hundreds of stress state inductions in many animals during dobutamine, norepinephrine, or the combination. So it generally gets it right, even though it's noisy and overlapping in some cases. I'll kind of go through this a little bit faster. This is some of the raw performance data looking across the 4 classes at true positives and false positives. Overall, the algorithm performs at 92% accuracy. And again, this is the ANN, or the artificial neural network, in gray. If you take away its ability to remember things, again, removing the LSTM layer, you have a drop in performance, and this algorithm outperforms other classifiers that are a little bit more simple, like a support vector machine or a linear discriminant analysis. So this is good. We have an accurate algorithm, even though the data is complex. Can we put the algorithm in charge? Really the last couple slides here of bioelectronic control of cardiovascular state in order to reverse these things that are happening during the ischemia induction. So this is a cartoon of the closed loop control, again, stimulating the same nerve, again, revisiting the question of what else can this left cervical VNS implant do? Can we use it during different cardiovascular disease events, right? Beyond just the rehab boosting components that I mentioned prior. This hypothesis was tested across 3 different experimental conditions. either ischemia alone, which is the combination injection of the catecholamines at high doses that can cause an infarct and injury. The second case is in red, where we put the AI in charge of triggering VNS. So if it accurately detects ischemia happening again spontaneously, it will trigger VNS in order to potentially bring the system back down to really just establish energetic imbalance in the myocardium. Lastly, at the bottom here in B, is really the most common way bioelectronic medicines are programmed, as you might know in the clinic, which is open loop. So just like a really bad stoplight, it's on and off no matter if there's cars there or not. This can be problematic, right? If we have an episodic ischemia event and we're just pre-programmed, we might miss things altogether. And that's really the gist, as you saw prior. There might be timing requirements in order to maximally affect things bioelectronically. So again, happy to go into some of the details here, but some of the main effects are shown in panel C. Really critically, and it's one of the most standard biomarkers. We see a full reversal when we put the ANN in charge of VNS. Again, it's closed loop. It's reacting accurately and it's stimulating the vagus. We see a full reversal of ST segment depression, which is indicative electrocardiographically of subendocardial ischemia. If you're in the magenta group and open loop pre-programmed VNS, which might just miss these events, you see no benefit electrocardiographically or in terms of improving afterload or rate pressure product. So this is almost the same as ischemia alone. Again, it might just be missing these events that are episodic and spontaneous. And you do see benefits in afterload with the closed loop control in red, or even rate pressure product, which again is an index of myocardial oxygen consumption. Last piece of data here, and then we'll close up and open up for questions. We did look at many side effects, including breath rate. So when you stimulate the vagus, you're also activating the recurrent laryngeal nerve, which can lead to hoarseness, coughing, and affect breathing. We didn't see any differences in breath rate across the 3 different independent variables, but we did see significant benefit in biomarkers related to ECG restitution. So this is, in this case, quantified as the QT-TQ ratio that then can affect arrhythmia probability. So we didn't get arrhythmias to go away fully. They were still there during these intense cardiovascular stress states, but we did see a significant reduction compared to ischemia, again, with this closed loop reactive control. So overall, this might be a promising way to maximize this implant if it costs X dollars and has Y risk. It's very exciting. It's something I'm very excited to potentially look into and leverage the expertise at the Miami project and the university at large to really get the most out of these bioelectronic medicines and help patients with other comorbidities. So this is very early unpublished, but still I'm very excited about it. So lastly, again, I'll go through this kind of fast. There's a lot of closed loop bioelectronic medicines out there, and using AI in medicine is a very tenuous topic. Many people have very strong opinions. A lot of this sounds like Star Trek-y type of, hey, I'm going to have an algorithm that's going to magically do X, Y, Z. There's actually many FDA-approved AI medicines, which I'll overview in just a second. In terms of closed loop VNS, there's many examples, one of which is for epilepsy by LivaNova, where the left cervical vagus is stimulated via tachycardia signals that an algorithm deciphers in order to look at correlates of an oncoming seizure. So it's for seizure prevention using kind of ECG-related features. And we already saw the microtransponder data as well, which is a closed loop reactive bioelectronic medicine that's now FDA approved. Deep learning is a form of AI using many layered networks. We showed a 4-layer network prior that can even show superhuman performance when tasked to detect things like AFib, AV block, SVT. This is a performance curve here where the algorithm's in blue outperforming expert cardiologists, which are the red crosses. There's a lot of these examples of AI that can potentially do better and look at different things than humans and maybe even help physicians in the future. And as I mentioned, this sounds advanced and Star Trek-y, but there's over 30 FDA-approved AI-based medicines right now, and that's growing every month, mainly in the field of the radiological workflow, looking at enhancing the capability to see things in images or even oncology. And in blue, there's a lot of, if you want to look up this paper, it's fantastic, a lot of emerging AI-based medicines for cardiovascular, even things on your cell phone where you can look if you have AFib or not. So this is an extremely exciting direction that the field is going, not just using bioelectronic control for treating disease, but maybe also using AI to control this. So excited for the future of the field, and obviously very excited to do this here and continue this at the university and the Miami project and BME. So in closing, a lot of people to thank. These teams are loaded with talent. I've been very lucky to be a part of them. Again, at the top, thank you to the leadership here for getting me here. I'm super excited for our future together, looking at this subject matter as well as other things that we can win together on. Battelle, a lot of this work was done at Battelle, which has an extremely deep bench of talent and leaders in neurotech, individuals that are statisticians, again, AI gurus, and at Texas, the great work they're doing there to translate this targeted plasticity therapy to stroke, SCI, PTSD. They have a really big vision for this. So it's been quite a ride, and excited to continue it here in Miami. Thank you for your attention. I guess we'll open it up for questions.
Hey, Patrick,
that was just wonderful. Thank you for that, your review on stroke and spinal cord injury, and finally myocardial disease. I was just thinking before I asked Jim to ask a question. You know, a lot of people are walking around with heart monitors already. So I guess the vision is to kind of, in concert, put both the detection and the closed loop activation system in parallel with those types of sensors to prevent myocardial ischemia, to prevent myocardial infarction. And that makes a lot of sense. But how about people that, you know, are having a heart attack? I mean, just like when you talked about stroke, a rat has a stroke or a rat has a spinal cord injury, and then sometime after that you improve function. Do you think this could also be used and after someone actually has some ischemia to the heart?
I am not a clinician, and there are many experts in the audience. My understanding is that the recurrence of stroke is high. If you have one, you have an increase in probability to have another. Heart attack, I don't know the statistics, but if there is damage, which then leads to subsequent myocardial melee and dysfunction, which I think is, again, I don't have anything at hand to substantiate the hypothesis, but if that's true, then you can say, hey, ischemia and another infarct may be coming along, right? If the patients don't respond to revascularization or beta blockers or PCI. So yeah, I think that before a first like a significant event or after, there's many reasons to hypothesize that it can be beneficial for that whole spectrum. I think that's a really good point, to not just get on the first episode, but maybe even improve and prevent inflammation in the long run. VNS is involved in a lot of inflammatory mitigation by decreasing inflammatory cytokines. So after an MI, do you need to keep inflammation in check? Would that be helpful? So there's the acute effects, there's chronic, there's a lot of really cool, exciting ideas and hypotheses. So that's a great question. That's my understanding.
Thank you, Jim.
Patrick, I wanted to thank you for your presentation. You know, one of the things that we've learned from epidural stimulation and other forms of stimulation is that we can drive the physiological system in different ways than nature does. And so my question is whether with VNS stimulation, you can interleave different patterns of stimulation to shape the effect that you like another thing that's come up in the epidural stimulation world is the use of burst stimulation. So I'm just wondering, can we get out of the vagal system different shapes of responses by changing the way you stimulate the nerve?
This is another fantastic question, and it's a vector that the field is generally going on. We used very simple stimulation here. It's just we're not modifying any stim parameters. It is known that there is a vagotopy, just like there is organization in many neural tissues. There's modularity, there's layers, there's dorsal horn and XYZ. Tom Steiglites and others are using current steering, similar to DBS devices, in order to potentially only maximally modulate parts of the vagus where you might have aortic baroreceptor fibers or GI affecting fibers and circuits. So that is definitely further behind the epidural space, but nonetheless, stimulating nerves in a current steering or burst stimulation space is starting to be explored. Another last thing I'll mention to answer the question is there's also anodal and high frequency block that's being investigated, where you have multiple cuffs, as you may know, in order to block afferent volleys or fibers that are traveling in one direction. So high frequency, maybe Warren Grill would say it's around 10 kilohertz stimulation, could block normal lower frequency, classic 50 or 30 hertz stimulation, so that you only get fiber activation in one direction. So it's a really great question. These are being tested clinically as well. And so I think that's an exciting way to optimize nerve stim and piggyback, like you said, on some of the epidural aspects and tricks and twists. Yeah.
Thanks, Patrick.
Yeah, thank you.
I think Mark has a question.
Yeah, Patrick, really nice presentation.
Thanks.
First of all, going back to the question about myocardial ischemia, there's a belief post-MI that all MIs become transmural. They go to completion is the term that is used. And certainly that's what drives the pharmacotherapy with beta-adrenergic blockers and ACE inhibitors. But it would be interesting after an event to look at this. That's one possibility. The second is, I know of no studies that have looked at rate pressure product, as a proxy for myocardial ischemia with any stressors in spinal cord injury. Those stressors, being autonomic dysreflexia or orthostatic repositioning, or even postprandial stress, which we talked about yesterday. So
Right.
This could be intriguing either from an acute, prophylaxis for them, or some conditioning effect that results from repeated episodes of VNS exposure.
Yeah, I agree. And I think, as you know more than I, there's a really deep expertise in many things at the med school in Miami and the project, including inflammation. And so if you can modulate inflammation vagally or pick another nerve, this is a huge unexplored landscape. I mean, everyone's vagocentric because it does so many things, right? Especially at the cervical level where all the fibers are together. But yeah, having prophylactic or inflammatory modulation or RPP triggered for AD, I still have to learn a lot about AD and leverage a lot of the expertise here at the project to think about how to use it for that. But the future is very bright, I agree. And there's a multitude of ways that we can win together on that, inflammatory or even just acute cardiovascular effects. So totally agree.
Patrick, this is John.
Hey.
I have a philosophical question for you.
Sure.
So you mentioned a couple of times that this use of deep neural networks is a little Star Trek-y or frightening to people, which I suppose has a lot to do with the fact that how it works can't be explained. And I personally don't see why it should have to be explained when pharmacotherapies, for example, can't be explained. And I wonder if you see that that resistance as part of a problem for the future of more AI and deep neural networks involvement?
Yeah, this is another really, really good question. All of these things are quite hot in the field. There is a thing called, and many of you may know this, explainable AI. So it's not just a term, it's a huge component of the AI research to say, if R to R changed and ST level changed, show me the logic of what's happening in the network, right? You have 70,000 here, which is not a lot of learnable parameters. Can you bucket them and start to look at what happens logically? The explainability and interpretability, opening up the black box, as it's called in the literature of AI, is a huge, I think, challenge and burden for clinical adoption. And even you talked about a kind of a philosophical high level of abstraction here. Would you trust an algorithm that has this many parameters to stimulate your nerve? And what would you want to see in a graphical user interface? Would you want to see your stress state in 2 dimensions going to a terminus that you know is bad? So yeah, this is explainable AI, interpretable AI, and having it explained to clinicians who are, of course, massively critical stakeholders, as well as patients, how these things work, is a really hot field. In the bioarchives paper, we actually address that by doing some really cool dimensionality reduction techniques to take hundreds of dimensional representations of what the algorithm's doing into 2 dimensions. So you can see it, you can understand it, and visualize it. So it's a really good critical challenge, and we do address that in some of the work. I didn't have enough time to put the data here, but it's a great question.
Thanks.
Yep.
Patrick, it's Alan Levy. That's, again, a great talk. And
thank you.
And the question I had really sort of links on to John's a little bit, because, I mean, obviously the clinical studies are incredibly complex and involve clinicians who may not really understand as well as you do the mechanisms and components, and the diseases that you're treating are pretty heterogeneous, like, just as simple as stroke. I mean, there's so many different etiologies of stroke, including cardiac sources, carotid sources, intracranial carotid sources. And I'm just wondering, for that particular field of stroke specifically, is there a subgroup that you are looking at, or is it all comers? And my linking question is, if you need to link with any of the neurologists or cardiologists for continued studies, please let us know. But, is there any subgroup analysis of who may benefit more, or is it all comers?
Are you asking about the rehab component, a potential
For
cardio
stroke
component,
and for heart attack? I mean,
okay, so
the cardio component,
Gotcha.
because it's such a heterogeneous disease. I mean, when those trials were conducted, were they specifically looking at any comer with a stroke, or did they have subgroups that they were, for their inclusion, that they were looking at specifically?
This is another great question. That I don't have a great answer to, unfortunately. There's a lot of unknowns as you're getting at the profile of patients, the heterogeneity, the sources. Do they have coronary microvascular dysfunction and no obstructed arteries? There's a myriad of why strokes happen, as you know more than I. The inclusion-exclusion criteria for vagal stimulation, the closest precedent that I could think of is the Anthem, Innovate, and Nectar trials, which it was right-sided vagal stimulation was used for treating heart failure. You might know of these trials. The inclusion-exclusion, I think, was no previous acute coronary events like XYZ infarct. I don't know if they excluded based on triple vessel critical stenosis. So there is that precedent. This data is just in rodents, and there's a lot to learn. So you ask a great question of how could you eventually navigate what patients to select. And I would love to leverage the expertise of the project and the med school to answer that. But you can use some of the heart failure vagal mod trials to maybe get at who responded, although HF is much different than ischemia. Can you prevent strokes? I think it's a good question. That's my best stab at it. There's a lot of open components there. So.
Thank you.
Yep.
Patrick, this is Jacques Morcos, one of the neurosurgeons. Welcome to Miami, by the way.
Thank you.
Two questions, one specific one and one maybe in the philosophical realm of Sean's question earlier today. Specific question, subarachnoid hemorrhage due to ruptured brain aneurysm. There is some work in rodents on trigeminal nerve stimulation to mitigate vasospasm, which is quite a deadly complication in many times, between day 4 and day 12. Any comment or any experience with that? Do you see that part of the field going anywhere?
So you're talking about cerebral hemorrhagic insults, maybe mitigated by vasospasm, or rather caused by vasospasm?
Yeah, no. When aneurysms rupture in the brain and cause hemorrhage, there is a significant incidence of vasospasm, of the arteries going into constriction, and it's been studied for decades, and we don't have a perfect way to solve it. But there has been some work on stimulating trigeminal nerve. It's mostly in rodents and shown to perhaps decrease and mitigate cerebral vasospasm. I was asking if you had any interest or experience in that field, or have any comments on it.
Sure. So it's a very good question. I can answer from the coronary vasospasm angle. I don't know much about cerebral vasospasm. You might know that cholinergic effects in healthy animals or humans, or individuals or animals with disease, VNS or cholinergic application can have paradoxical effect on vasospasm, such that in healthy animals it should lead to coronary vasodilation, maybe through presynaptic inhibition of neuroadrenergic kind of alpha-1 activation. But during disease, you get a paradoxical activation and constriction, and maybe you can even provoke vasospasm using cholinergic application. Again, this is from the coronary point of view, my limited knowledge. So I guess said differently, VNS and muscarinic effects are very heterogeneous depending on the state of the endothelium and the dysfunction. And so if the mechanisms are similar in the coronaries as well as the cerebral vasculature, VNS in healthy animals might give you the opposite effect that it does in disease. So yeah, that's as much as I know, and some hypotheses. Yeah.
Mike, I have a question.
Sure.
Yes. Yeah, thanks, Patrick. Mike Ivan, one of the other neurosurgeons here. Fantastic talk, really provoking. I just had a question about your thoughts on transmagnetic stimulation, TMS, and how that's a lot of there is a lot of data with kind of restorative actions of it after stroke and injury in the brain. It's non-invasive. It's more directed towards specific pathways. Do you think there's pros and cons, or do you think there's a way for them to work synergistically with VNS in the future?
Another very good question. TMS paired with rehab, or just grossly on, during rehab in an open loop fashion, or TDCS, pick your transcranial modulation type, is well studied and it's being disseminated widely. There is some reasonable effects. Can they be used synergistically? I'm sure they can. One hypothesis that comes to mind is, since VNS is so targeted, and maybe it doesn't lead to full arousal states in a distributed set of tissues, can you, as an adjuvant, add in TMS with VNS pairing to get the brain more responsive to VNS? Is there a potential synergism between kind of the really large neural tissue volume activated with TMS, and then the temporal, maybe smaller subset that's activated with VNS. That's one hypothesis. My biased mentors would say that you need to have timing and you need to stimulate the vagus. And so I think more broadly, at its core, VNS plus rehab has a plus sign, right? And so other plus signs are definitely welcome. Maybe even stem cell implants, right? Can you actually have enhancement of an implanted graft via pro-plasticity factors, or using VNS to mitigate inflammation? That's a big problem with cell therapies. So yeah, there's a number of hypotheses for TMS potentially teaming up with VNS and rehab. And yeah, I think it's a really good question, because a lot of people are using it, and some patients may start enrolling in this, since this is FDA approved now, to get better benefits. So it's a great question.
Very good. So one more question, Eva.
Yes. Hi, Patrick, and thank you so much for a wonderful talk.
Thank you.
As you know, neuropathic pain and chronic pain is a huge problem after spinal cord injury. And it's very interesting, these types of therapies where you stimulate the vagal nerve, and in particular, the connection with Lucus ceruleus, which is, as you know, part of the endogenous pain inhibitory system. So I wonder if you have any comments regarding this and the potential utility.
Yes, this is you're asking fantastic questions. This is a great conversation. So as you mentioned, you have the descending inhibitory LC circuits that can mitigate sensory afference. I think that's kind of what you're poking at there with VNS. If you were to talk about a spinal centric mechanism of how you can inhibit sensory information. Cerebrally, I believe, how much work is done with LC activation cerebrally for kind of dampening pain afferent signaling? I know the spinal story well, but not the cerebral.
No, I don't think there is so much work, but it's an interesting connection with the endogenous pain modulatory system. So, it's one potential avenue.
Yeah. So if you were so there's the acute effects, right? You can have descending inhibition via LC activation. A way to answer it in the paired paradigm, if you will, is that if you have, I think we talked about this during my interview, but if you have gross expansion of somatosensory representations in S1 that maybe are underpinning or contributing to neuropathic pain, can you use VNS pairing to expand the neighboring dermatome representations, maybe shrinking down the S1 representation and therefore concomitantly affecting positively neuropathic pain? That's a little bit, we mentioned Star Trek-y. However, that's how, I didn't get into all the VNS pairing work. That's how the VNS for tinnitus works, where you have the tonotopic organization and auditory cortex after cochlear damage. Tones that are associated with ringing will expand. And the VNS pairing, again, is with an event for tinnitus. It's with sounds to expand the neighbors back so that you can indirectly affect the tinnitus frequency representing components of cortex. So if doing a similar thing in S1, how to use it pairwise, like pairing it with an event, pairing it with touch on other regions that are not noxious. There's a lot of really cool hypotheses there. I'd be happy to talk about that with you, but I guess that's my take on the immediate effects versus paired effects.
Yeah, a lot of things to do. I think everyone can appreciate, why we are so excited to have Patrick here at the university working with the Department of Neurological Surgery as well as the MIND project and biomedical engineering. So thank you very much, Patrick. And he's on the first floor of the Lois Pope Life Center. So just stop by and knock on his door, and you can talk more about science. And there's great potential for collaborations, great potential for combination therapies. I mean, think about it. VNS stimulation plus stem cells, plus swan cell transplantation, plus pharmacotherapy. There's all kinds of things that we can think about, both preclinically and clinically. And I think it opens up great opportunities for program projects and things of that nature. So have a great day, everybody. And thanks for joining us. Thanks again, Patrick. Take care. Bye-bye.
Hey, thanks, everyone. Have a good day.